Hi, everyone, and welcome back to the Generalist Low Risk Obstetrics podcast. We are your hosts, Kyla Freeman and Patricia Massel, rural family medicine residents out of Alberta, and family medicine resident hopeful, Caitlin Blewett, fourth-year medical student from UBC.
Today, we're going to talk about emergency contraception.
For this episode, we've drawn on various resources, including SOGC guidelines, up-to-date, and a few handy websites that we will link to in the show notes. As always, we do not represent any of those organizations, and any opinions expressed are solely our own.
This podcast was written by Caitlin, an expert review by Dr. Ashley Musey, an OBGYN with Fellowship in Family Planning. A huge thank you for her time and support. Let's get started.
Okay, I gotta say, team, I really loved writing this episode, and I think it's a really important topic for every family doc to have under their belt. You don't really need to have any low-risk OB leanings at all. Let's start off by defining emergency contraception. This is a category of medications or interventions that we can use to prevent pregnancy after intercourse but before implantation of a fertilized embryo.
This is one of the most important counseling points for patients. Emergency contraception is not the same as an abortion. It will not abort a pregnancy that's already begun. In other words, if the sperm and egg have found each other and that little blastocyst has found the endometrial lining of the uterus and snuggled right in there, these methods will not stop that pregnancy from continuing. So let's start off with the methods themselves. Then we'll touch on some efficacy and mode of action information. There are currently two options for emergency contraception in Canada: oral hormones and the copper IUD.
Let's start with hormonal methods. We've got 3 to choose from.
The first group of hormonal options contains levonorgestrel, a progesterone. There are a couple of brand names to choose from here. You may have heard of Plan B, Norlevo, Option 2, and Next Choice. Underneath the label, each of these is the same medication. 2 tablets of 75 micrograms of levonorgestrel that are to be taken together, making up a 1.5 milligram dose. Levonorgestrel is most effective up to 72 hours after unprotected sex, but there is some efficacy up to 5 days.
These are available without a prescription across Canada. Any pharmacy should be able to provide them, though they may be over the counter, meaning you have to actually ask the pharmacist.
The second hormonal option is ulipristal acetate, or UPA. UPA is a selective progesterone receptor modulator. In Canada, it's only available by prescription and sold under the brand name Ella. It's taken as a single dose of 30 milligrams and is effective up to 5 days after unprotected intercourse.
The final hormonal method is called the USP method, which I will admit I don't really know how to pronounce properly, but I'm going with USP, and uses combined oral contraceptives, or the birth control pill, to give 2 doses of ethinyl estradiol, 100 micrograms per dose, and LNG, 500 micrograms per dose, 12 hours apart.
Because we're looking for specific doses here, this doesn't work with just any old birth control pill pack, and it requires a prescription, and it's less effective than the other methods we'll talk about today. But this method can be convenient for people who are already using a brand of pills that work with the USP method and who aren't able to access a more effective method.
So let's talk about which brands this will actually work with. The SOGC has a great table of how to dose these, which we'll link in the show notes. Briefly, this method is possible with Alesse and its lookalikes like Alisena, Avienne, Esme, and Lutera. It's also effective with Min Orval and Triquilar, which is a triphasic oral contraceptive.
And importantly, it's 2 doses, 12 hours apart.
Okay, so definitely a more complicated option, but a great one to have in your back pocket, especially as a rural doctor.
For some patients, understanding that emergency contraception is not an abortive process is really important in deciding whether or not it's something they'd like to pursue. So let's talk about mechanism of action here for a minute.
Okay, so the levonorgestrel and the UPA both prevent ovulation. Levonorgestrel blocks the LH surge in the pre-ovulatory phase, inhibiting follicular development and therefore egg release. UPA has a longer window of efficacy than levonorgestrel because it directly inhibits follicular rupture, meaning it still works to prevent ovulation, even if taken shortly before the time when ovulation would otherwise have occurred.
So the big take home here is that neither LNG nor UPA prevent ovulation if the LH surge has peaked, and they don't prevent implantation of a fertilized embryo. So getting a good history of previous menstrual cycles and the timing of unprotected intercourse is really important when you're counseling someone about the efficacy of different emergency contraception options.
So, in summary, we have 3 medication options for emergency contraception: LNG, levonorgestrel, UPA, and the USP method. all of which work similarly. But these modes are definitely not interchangeable in terms of how good they are at actually preventing pregnancies.
Nice, Patty. I also really wish that I could show everyone as you counted us down the options. I appreciated it.
Keeps me on track.
UPA is the most effective oral option that we have, with pregnancy rates from 1.2 to 1.8% up to 5 days after unprotected intercourse. Levonorgestrel is slightly less effective, with pregnancy rates of 1.7 to 2.6%, and is best used in those first 72 hours after the unprotected intercourse. With both methods, the earlier they're taken, the better.
There is some evidence that increased weight can decrease the effectiveness of oral LNG as an emergency contraceptive, but this is definitely not a reason to withhold access to LNG if that's the best option for the patient. If UPA is accessible and affordable, however, it would definitely be reasonable to choose it over LNG for people with a BMI over 25.
The USP method is the least effective oral option and has the most side effects, but it's still safe, inexpensive, and very accessible if someone happens to already have a pill type that works with the method. The side effects are mostly estrogenic and include nausea and vomiting, so prescribing an anti-nausea medication to help your patient feel more comfortable is a great move.
Now that we've covered the oral options, let's talk IUDs. Though they are not the most beloved form of birth control by everyone, they are certainly the most effective emergency contraception, and they have the added benefit of great long-term contraception for bonus points.
In Canada, it is the copper IUDs that are approved for emergency contraception, and we officially have the Liberté, the Mona Lisa, and Flexi-T to choose from. However, the SOGC does note that other brands can be used off-label as well.
Heck yes, the copper IUD is actually the most effective form of emergency contraception we currently have, and it's effective for a longer window than the hormonal options. A systematic review of 42 studies showed that people who have a copper IUDs inserted up to 7 days after unprotected intercourse, that's a whole week folks, have less than 1% risk of pregnancy at follow-up. That's pretty good.
In terms of how the copper IUD prevents pregnancy, this is a little bit unknown, but who doesn't like a little bit of that? We don't really know exactly how it works when it comes to mechanism of action as compared to our hormonal options, but we do know that copper IUDs produce a sterile inflammatory response in the uterus and are toxic to sperm and eggs. They also increase contractility of the myometrium and a smooth muscle action in the fallopian tubes. So basically, we speculate that some combination of all these little features prevents that pregnancy from taking hold.
This all boils down to essentially a hostile environment for sperm, eggs, or any combination thereof.
I seriously love IUDs. What can't they do? While we're on the topic, let's talk about the Mirena IUD and emergency contraception. In 2021, the New England Journal of Medicine published a study that showed non-inferiority of the Mirena IUD compared to copper IUDs when it comes to emergency contraception. The trial included participants who had presented for emergency contraception in the US within 5 days of unprotected intercourse.
The outcome measured of the trial was a negative pregnancy test 1 month after IUD insertions. The researchers were successful in showing non-inferiority of Mirena IUDs. This means that only 0.3% of Mirena IUD recipients were pregnant within 1 month, and similarly 0% of copper IUD recipients were pregnant within 1 month of the trial.
Wow, so this is super exciting stuff. I mean, we love the copper IUD emergency contraception, and it's highly effective long-acting contraception. But some folks just don't find that their periods are manageable on the copper IUD, and they end up having it removed early. The Mirena IUD has a much better tolerability profile as a long-acting reversible contraceptive, and having it also available for emergency contraception would just be amazing.
So hang on to your hats and keep your eyes peeled for updates from the SOGC about using Mirena as an emergency contraception in Canada.
All right, let's quickly touch on reasons to not give emergency contraception. We're talking about contraindications here. There are no absolute contraindications for emergency contraception other than known hypersensitivity and pregnancy, because these methods simply won't work. As we've discussed, emergency contraceptive methods won't stop an existing pregnancy. But that being said, you certainly want a negative pregnancy test before inserting an IUD.
It's important to note that even people who have contraindications for regular use of combined OCPs can safely use oral hormonal emergency contraception, because the exposure to hormones is very brief.
The copper IUD has the same contraindications for use as an emergency contraceptive as it does for use as a long-acting reversible contraceptive, and a pregnancy test, again, should always be obtained before insertion.
In this section, we'll talk about routine follow-up care and counseling for emergency contraception.
People who have used any form of emergency contraception should expect a period within 3 weeks. Make sure to counsel them that their period could be early, it could be late, could be heavy, could be light. Anyone who doesn't have a period in that 3-week window should have a pregnancy test done, and if it's positive, pregnancy options and counseling should be provided.
In terms of follow-up and contraception going forward, if your patient optioned for an IUD, then all that's needed is to remind them to use barrier contraceptives or abstinence for the first 7 days, and then come back for an IUD string check 4 weeks after insertion.
If the person has opted for an oral emergency contraception, then asking if they're interested in long-term contraception options is always worthwhile. I ask it of everybody. Love long-term contraception. For people using UPA, they will need to wait 5 days before starting hormonal contraception because progestins actually interfere with UPA's efficacy. Send them home with a script for UPA, their preferred hormonal contraception, and a reminder to use barrier methods or abstinence for the 5-day waiting period and those first 7 days of their new contraception.
And for people using the oral levonorgestrel or the USP method, they can start a hormonal contraceptive that same day, but they should again use backup contraception for the next 7 days.
There are lots of nasty rumors out there, so please take a moment to reassure all your patients you talk to about emergency contraception. Firstly, remind them it has no impact on their ability to get pregnant in the future if they want to. Secondly, using an emergency contraception does not increase the risk of future ectopic pregnancy. All the emergency contraceptive methods we've discussed are also safe for people who are breastfeeding.
Now our favorite section, the pearls. 1. Progesterone-based emergency contraception includes Plan B, Norlevo, Option 2, and Next Choice. These are available at the pharmacy without a prescription, although you might have to ask the pharmacist to access it. These are all packaged as 2 levonorgestrel pills. Patients should take both of them at the same time. Oral LNG is most effective within 72 hours of unprotected intercourse.
2. UPA requires a prescription and goes by the brand name L. It's usually 1 pill and it's effective for at least 5 days after unprotected intercourse. It is also more effective than oral LNG for folks with a BMI over 25. You need to wait 5 days after taking UPA to start back on hormonal contraceptives.
3. The USP method uses oral contraceptives in specific doses and only works with the less than its alternatives, Min-Avril and Trequilar. You need to look up how many pills of which brand are needed, and dosing is 2 doses 12 hours apart. This method is less effective, but more accessible for some patients.
The copper IUD is the most effective emergency contraception and also a great long-term contraceptive. It is also very effective for folks with a higher BMI.
5. Keep your eyes peeled for an exciting update from the SOGC about the potential use of Mirena IUDs for emergency contraception, but not currently ready for practice as of March 2022, but hopefully soon.
And that wraps up our episode on emergency contraception. Thank you guys so much for listening. We hope you enjoyed this episode.
And remember, you can connect with us via the same generalist email as you do for any of the CCFP podcast questions or suggestions, hello@thegeneralist.ca, and you can find us on Twitter and Instagram. Show notes, of course, are going to be available on the Generalist website under the Low Risk OB section, and we look forward to bringing you another episode soon. Have a wonderful day, and good luck on the wards.